Now for fluid volume balance. In this video, we're going to be going over pathophysiology of body fluids, key terms for fluid physiology, as well as fluid volume overload and deficit. And also, finally, the tonicity of fluids, isotonic, hypotonic, and hypertonic solutions. So let's play the first segment right now.
Now, the human body is made up of 60 to 70% fluid. And as you grow older, H2O gradually decreases from birth to old age, usually because of muscle mass, which holds water and gradually decreases with age. This is why our infants and elderly patients are most at risk for fluid imbalances. Now guys, just think of your sweet grandmother here. Our elderly populations are most at risk for fluid imbalances like fluid volume overload. Now, due to heart failure or broken kidneys, something called renal failure, or on the other side of the coin, dehydration from not drinking enough water, or usually because they're not thirsty or forget. Now, what are the top 3 factors that mostly influence fluids? Number 1, we have muscle. Number 2 is body fat. And 3 is gender. So starting with muscle. Muscle holds on to water. Guys, please write that down. That's a huge test tip. But also skin and blood contain the highest amounts of water in the body. So technically, obese patients have less fluid than those who are thin because fat cells repel water, kind of like how oil floats on the top of water. Now, I used to be a personal trainer for a long time, about 8 years, and I always used to think obese people had more water retention because I thought that's what made them bloated. But it's actually the opposite. Obese people have less total body water than a lean person. For example, if we had 2 patients here at the exact same weight, both weighing, let's say, 200 pounds. That one patient who's 200 pounds of muscle and another patient who's 200 pounds of fat. Well, the obese patient would be most at risk for fluid imbalances like dehydration because less lean muscle mass and more fatty adipose tissue. So it's easier to understand why in general, younger people have higher percentage of body fluids than older people. It's mainly the muscle mass. Now also, since men have proportionally more lean muscle mass than adipose tissues, aka body fat, in general, men retain more fluids than women. Now, body fluid is located in 2 main areas. Fluid inside the cell called the ICF, the intracellular fluid, and fluid outside the cell called the ECF, the extracellular fluid. So let's start with the ICF, intracellular fluid. So the fluid inside the cell. Our key electrolyte is potassium, who I call King Potassium. He's the king of action and contraction in your muscles. Now, he's the most abundant electrolyte inside the cell because the fancy sodium-potassium pump. So please just remember that potassium is pulled outside the cell to inside the cell. Now, as much as 2/3 of all fluid in the body are intracellular, inside the cell, but mainly in the skeletal muscle cells. Dang, that's like 75% of fluids inside the cell. And that's exactly right. This is where our electrolytes are floating to. Remember those electrolytes that light up the body with electric energy? So obviously it makes sense that electrolyte imbalances causes so much muscle problems. Now switching gears here, let's change to the fluid outside the cell in the ECF, the extracellular fluid. This is the fluid inside the blood vessels, the skin tissues, and even the spinal cord fluid called CSF. It accounts for only 1/3 of body fluids. Now, technically speaking, 6 liters of blood that are circulating around our circulatory system, aka in the vascular spaces, and 11 to 12 liters in the interstitial fluids, as well as 1 liter in the transcellular space, or basically the fluid in between our cells. Like our CSF, our cerebral spinal fluid around your brain and spinal cord, your pericardial fluid, all that fluid around your heart muscle, your synovial fluid, your joint fluid, your intraocular fluid, your eye fluid, your pleural fluids, known as your lung fluids, as well as your digestive secretions, your intestinal fluids. Now, fluids are gained and lost via a few main organs. Mainly, number 1 is the kidneys, which I call the washer machines. Number 2 is the skin, then we have the lungs, and then lastly is our Mr. G.I. Joe himself, the GI tract. Now starting with your kidneys, the washer machines of the blood also serve as the doors to your body that let fluid out of the body and into the body. Now normal daily urine output is 1 to 2 liters in a normal healthy adult. Now technically speaking, 1 ml of urine per kilogram of body weight per hour for all age groups. Now that's just really fancy words for about 240 mLs of urine in 3 hours. Basically 8 ounces or 1 cup of urine in 3 hours. Now the minimum amount of urine per day that is needed to excrete toxins and waste is between 400 to 600 mLs. So guys, if your patient is not having urine output for at least 240 mLs in 3 hours, or 480 mLs in 6 hours, or basically a half a liter halfway through your nursing shift, well guys, there's a huge problem. Your patient should be excreting almost about a liter through a 12-hour shift. Now, if your patient's not excreting this much, well then something's probably wrong with your patient's kidneys. So your patient's probably going to have a bunch of toxic waste inside the body and not in the body. Now, a little side note here, this is why INOs, input and output recording, is so vitally important, because it tells us early on if your patient has a kidney problem or not, rather than waiting around 24 hours for all those lab reports every day to come to see if your kidney labs are high. Technically speaking, we can look at the BUN and creatinine levels to see if the kidneys are actually involved. But a quick side note to the side note, if both BUN and creatinine are high, it's usually an indication of renal failure problems. But guys, if only BUN is high, it's usually a dehydration problems, because I call this the burn bun syndrome. Kind of like if you went out suntanning too long and got your buns burned. So if you have high bun, it basically means your patient is dry. Next, we have the less important GI tract. 100 to 200 mLs daily is normal, even though approximately 8 liters of fluid is circulating around in there. Now, a real important test tip here, so write this down. Diarrhea and fistulas cause large fluid losses. Alright guys, next is our fluid loss through skin, also called sensible losses or sensible perspirations. This refers to visible water and electrolyte losses through skin, known as sweating, or even diaphoresing, profuse sweating. The chief solutes in sweat is sodium, chloride, and potassium. Now, this particular loss increases during conditions like fever, heat stroke, or even hot patients during like thyroid crisis. Due to an increase in metabolism, you usually get really hot and sweaty. Alright, now a little side note. For every degree that increases in body temperature, insensible water losses increase about 10%. So an increase in like 8 degrees increases 80% of insensible losses. Now lastly, burns, which a lot of students forget about, but burn patients are the most at risk for fluid volume deficits because they lost a ton of water from the blister formation on their burned skin. Now finally, the lungs also causes insensible losses, usually at a rate of approximately 300 mLs per day. Now the loss only becomes very serious at an increased respiratory rate or even in dry climates. So monitor your patient with respiratory alkalosis, a big key word there. These patients usually have hyperventilation called Kussmaul respirations. That's a huge keyword that loves to show up on tests. Yeah, basically you end up panting like a dog and blowing off all that CO2, that carbon dioxide, I call carbon diacid. So panting like a dog, I call it respiratory alkalosis, because it's acid that is leaving the body via carbon dioxide, making your body this alkaline state. So guys, don't forget respiratory alkalosis, okay?
Okay, now let's cover a few key terms for fluid physiology.
Today we're talking about osmosis, diffusion, and filtration for the fluids in your body. Now let's go through some fancy medical definitions. Now, diffusion is the movement of solutes from an area of greater concentration to an area of lesser concentration, leading ultimately to equalization of the solute concentrations. It occurs through random movement of ions and molecules. Now, a great example of diffusion would be the exchange of oxygen and carbon dioxide, also called CO2, inside the lungs between the pulmonary capillaries and the alveoli. Now, osmosis is kind of like the wet version of diffusion. So osmosis is the movement of fluid from an area of lower solute concentration to an area of higher solute concentration with eventual equalization of solute concentrations. Basically, the whole goal of diffusion and osmosis is to balance and equal out the playing fields here. So we don't want any clumping or crowding. It's all about sharing here because sharing is caring. Next term is filtration. Basically, the movement of water and solutes occur from an area of high hydrostatic pressure, key word here, to an area of low hydrostatic pressure. Now, the best example of this would be in the kidneys, basically the washer machines of the body, that filter approximately 180 liters of plasma per day. Oh my gosh, that's like a ton of plasma. Oh my gosh, I know, right? Now, filtration is simply a passage of water and electrolytes through the arterial capillary bed in the interstitial fluid. It's all about fluid pressure, also called hydrostatic pressure, resulting from pumping action of the heart. All the way from the aorta down to the kidney washer machines directly. This pressure put on the kidneys helps the filtering process and helps the body wash out all the toxins and excess waste. But mainly they wash out HUC, hydrogen ions, which are acidic, urea, also called BUN, a byproduct of protein metabolism, as well as creatinine, a byproduct of normal muscle function. But we'll get to that later in our kidney videos. Our next term is osmolality, which refers to the number of osmotically active particles per kilogram of water. It's simply the concentration of the solution. Basically, how heavy and concentrated is it? Now, osmotic pressure is measured by millimoles, or MOSM. Now, the normal osmolality of blood plasma is about 270 to 300. Alright, so who cares about this and why is it hugely important? Well, when we're talking about isotonic, hypo, and hypertonic fluids, you know, the fluids that you're going to be tested on in your exam probably like next week, well, this becomes very, very important. Isotonic fluids have an osmolarity nearing 300, which is almost the exact same as human blood. It doesn't cause any fluid shifts outside the vascular spaces, so all that fluid stays inside the blood vessels. It's iso-perfect. There's enough pressure on each side of the membrane to really satisfy both parties. So iso-perfect. Next we have our hypertonic fluids. You guys remember those skinny cells? Skinny like a hyper person. So these are fluids with osmolarities that are greater than 300. Basically, they suck that fluid out of the cell, making it super skinny in hypertonic solutions. The solution in hypertonic fluids have an osmotic pressure that is greater than the body's. So the fluid from the body is being pulled out of the cell into the vascular blood vessel spaces. Now this is done in order to dilute and equalize the osmotic pressure from this thick hypertonic fluid. Last but not least, we have my favorite, the hypotonic fluids. Basically big like hippos, so I call them hippotonic fluids. These have osmolarity of less than 300, basically less than the body's normal osmolarity. So the osmotic pressure is greater in the body. Therefore, when hypotonic solutions are infused to the vascular spaces, like in your blood vessels, then the fluids are pulled out from the blood and into the cell, making the cells big and fat and swollen like big hippos. Kind of like a magnet that draws fluid from the blood vessel space and into the cell. Now the cells become big hippopotamuses, so hypotonics are big hippos.
Now switching gears to fluid volume overload, that overhydration. Clients have an overload of fluids. So just look at the O's here and think overhydration for overload. Now the other names, this can also be called fluid volume excess, hypervolemia, and FVO, the short acronym for fluid volume overload. So clients puff up like a big old water balloon full of fluid. And naturally, this leads to big manifestations or signs and symptoms of edema, the swelling of soft tissues as a result of excess fluid accumulation. Now, although edema can affect any part of the body, it's more common and more noticeable in the lower extremities, like the legs and feet, especially toward the end of the day, because fluid pools while people maintain an upright position. So grading the pitting edema ranges from 0 to 4+, making the skin look like a memory foam mattress. So please be sure to write this down. 4 different textbooks say 5 different things, but these were the ones that were based on the NCLEX standards. So be sure to write these down. 0+ is no pitting edema. 1+ is 2 millimeters or less, basically mild pitting edema, and immediately rebounds for skin. Now 2+ is 3 to 4 millimeters, which is considered moderate. We have a 15-second rebound of skin. And 3+ is 5 to 6 millimeters. This is moderately severe. It takes about 30 seconds to rebound. And lastly, number 4 is the 4+, 8 millimeters or deeper. This is very severe. The skin stays indented for about 1 to 2 minutes. so it doesn't rebound until after around 2 minutes. Now, for the top 4 causes of edema, these are the 4 underlying pathophysiological processes responsible for the manifestations of edema. So number 1 is a huge test tip: increased hydrostatic pressure. So let the name help you here. Increased means high. Hydrostatic pressure is just fancy words for water pressure. Remember, hydro means fluid. So think high fluid pressure within the blood vessels, causing fluid to be pushed out of the vascular space, or the blood vessel, and into the interstitial space, resulting in edema. So we see increased fluid volume, and the manifestation here is high blood pressure and pitting edema, basically worsening edema here. So a great example of this is renal failure, where the kidney washer machines fail to filter the blood and let excess fluid out of the body and into the potty. Another good example is heart failure, where the heart fails to pump blood forward and now it backs up in the body and the lungs. So the memory trick here, just think HF for heart failure as HF, heavy fluid all over the body. Now the second main cause of edema is number 2, increased colloid osmotic pressure. As you know, where solutes go, well, fluids flow. Basic osmosis, right? Well, in the same way, decreased colloids within the blood, we have a decrease in fluid retention inside the blood vessels. You see, colloids serve to hold water within the vascular space, kind of like attracting it like a magnet. Normally created by plasma proteins, namely albumin, that do not diffuse readily across the capillary membrane. So be sure to write this down. Low albumin, we have low plasma proteins. So the memory trick, A for albumin, A for attracts fluid into the vascular spaces. So without enough albumin in the body or in the blood vessels, fluid leaks out into the third space, meaning fluid escapes the blood vessels and into the body cavity like the abdomen. So examples of this would be cirrhosis with liver disease clients. Since the liver makes albumin, liver disease results in decreased albumin, allowing fluid to leak out of those vessels and into the third spaces. Another cause for low albumin is starvation, since there's no building blocks of protein being consumed to produce albumin. Now moving on to the third one here, increased capillary permeability. We have really leaky capillaries, those connections between the arteries and the veins, typically caused by severe inflammation or tissue destruction. And 2 great examples of this is bacteria causing infection and burns. So burns obviously damage the body, but specifically damage the capillaries, leading to edema from fluid leaking out of the vascular space. So let's play a little segment on pathophysiology of major burns. The pathophysiology for major burns. These can cause massive tissue damage and cellular destruction, resulting in widespread systemic inflammation that increases vascular permeability or capillary permeability. Just really fancy words for leaky blood vessels that fill up the body like a water balloon. So fluid, electrolytes, proteins, and other contents just spill over into the interstitial spaces or the third spaces. Clients end up with severely low fluid volume intravascularly within the blood vessels as fluid and electrolytes escape and now go into the tissues, eventually progressing into deadly hypovolemic shock, that severely low blood pressure that eventually causes death. This is why the number 1 intervention for major burns in the first 24 hours, and big NCLEX tip, so write down these key terms: IV lactated ringers, or LR solution, and IV normal saline, that 0.9% sodium chloride. These 2 will help save lives. They are isotonic fluids, which we call isoperfect fluids, since they stay inside the veins longer than any other solution, as it closely resembles the chemical composition of human blood. Fancy words for it increases the fluid volume inside the blood vessels, increasing the blood pressure and saving your patient's life. So don't let the NCLEX trick you here. We're not administering 5% dextrose, that glucose in water, which is not an isotonic solution, and not 45% normal saline, or 0.45%. That's a hypotonic solution. Only isotonic solutions here. So write it down again. Lactated ringers or normal saline. Biggest NCLEX tip. Now moving on to the last major cause of edema. Number 4, the obstruction of the lymphatic system. As you know, the lymphatic system is a network of tissues, vessels, and organs that work together to clean the blood. I call the lymphatic system the Lysol system, or even the drainage system, as it works to clean the blood and get rid of any waste that cells make. It does this with the help of white blood cells called lymphocytes, which fight infection, and works to clean about 20 liters of plasma blood flow every single day. Wowza! That's a lot of fluid. So obviously, if this system gets obstructed or blocked, then we have a major problem with a major backup of fluid. So the main causes include cancer or a tumor blockage that blocks the lymphatic system, as well as infection, those big lymph nodes. Basically a traffic jam as WBCs overload the system from fighting infection. Now moving on to the next topic here, fluid volume deficit, a common manifestation of dehydration. So clients have a deficit or a decrease in fluid. So just look at the D's here and think dry for dehydration and a deficit of fluid. Clients dry out like a raisin in the sun, appearing sunken in, shriveled up, and very weak, which we'll get into the specifics of manifestations and signs and symptoms in a moment. But first, why does this happen? So the top 4 causes: vomiting and diarrhea, like from food poisoning, infection, or just too much alcohol, like after last semester's final exams. You know what I'm talking about, right? Tequila is never the correct answer. It's actually the most correct answer. I'm just kidding. Okay, now hot body and sweating also releases fluid, including fever, heat stroke, and even thyroid crisis. And severe burns. This puts the patient most at risk for fluid volume deficit, since they lost a lot of fluid due to blister formation on the skin. As well as urination drains fluid from the body and into the potty. But really the big ones to write down here are the 3 Ds: DI, DKA, and diuretics. So the top reasons that clients lose fluid in the clinical setting here is DI, diabetes insipidus. So the memory trick for the 3 Ds, just think DI, think dry inside. Clients diurese fluid like up to 20 liters a day. We're talking lots and lots of urine here. Now the second reason here is DKA, diabetic ketoacidosis. So with DKA, think D for dry. Now we go into all the details in the full DKA video, but real quick, DKA we see an increased sugar concentration within the blood, that hyperglycemia, typically caused by infection, which also dries the body out. And a common manifestation is Kussmaul respirations, basically fast breathing, which leads to insensible fluid losses from all that fast breathing. Okay, the last D is for diuretics, like furosemide and hydrochlorothiazide. Now these end in "ide", so think the body is dried. Now as you will learn, diuretics drain fluid from the body and into the potty. So we also have a loss of electrolytes here too, mainly potassium. Because as you know, where fluids flow, electrolytes go. Okay, now a quick side note before we go into manifestations. Compensation of fluid volume deficit and dehydration. Now the body tries to balance itself out by sending signals to increase that fluid intake. So we'll see increased thirst, the body's going to be holding on to urine, so we're going to have concentrated urine, as well as increased heart rate and vasoconstriction. Just think about it here. The body's trying to compensate or basically make up for the decreased fluid volume by pumping the little blood it has at a faster pace all around the body in order to perfuse or oxygenate the tissues here. So this is why we see increased heart rate and vasoconstriction. Now moving on to manifestations or signs and symptoms. Starting with fluid volume overload, also called hypervolemia. We see high fluid volume, like a big bulging body here. So just imagine a big water balloon filled to the max, right about to burst. Naturally, everything's going to be big and bulging, like a big old grape. So just think the body will present big and bulging with big fluid volume. Now on the other side, for fluid volume deficit, we see hypovolemia, low fluid volume with a low little body. So just imagine a shriveled up balloon that just popped. Naturally, everything will be skinny and shriveled, just like a dried up raisin. So just think, the body will present low and little with low fluid volume. So we see weight loss as well as water loss. Again, another helpful memory trick for clients with fluid imbalance. And on the other side, for fluid volume overload, we see weight gain. This means water gain. So the key numbers to write down is 2 to 3 pounds in 1 day and 5 pounds in 7 days. This is a very helpful memory trick for clients with fluid imbalances. But as you know, this is not the case for all weight gain. Maybe it could be from that nursing school diet with all that junk food with high sodium and sugar during those all-night study sessions. You know what I mean.
Wait, so how exactly does sodium enter the body? I don't know. This electrolyte stuff's confusing.
So as for the key numbers here, please write it down. 2 to 3 pounds in 1 day and 5 pounds in 7 days. This becomes very critical to save the lives of clients in worsening heart failure, also called heart failure exacerbation. So please write down these numbers because rapid weight gain means rapid water gain, leading to pulmonary edema and massive fluids inside the lungs, which can kill the client. So again, write down those key numbers. Now moving on to the cardiovascular system for fluid volume overload. We see high blood pressure, which can be very deadly. We're talking hypertension, 140 systolic, huge test tip. And another big test tip here is hypertension crisis, 180 systolic, huge risk for a stroke. Now this is priority since high blood pressure can kill the client via hypertension crisis, resulting in a stroke. We're talking blood pressure so high that it can rupture small little blood vessels within the brain, aneurysms here. And we also see increased central venous pressure, that CVP, with bounding pulses, big distended neck veins called jugular vein distension, that JVD, and even distended veins within the hands and legs. Now on the other side, for fluid volume deficit, we see a low blood pressure which can be very deadly, as well as orthostatic hypotension, huge test tip, be sure to write this down, lightheaded and dizziness upon standing. So the client is hypotensive due to that decreased circulating volume. Now this is priority since low blood pressure can kill the client via hypovolemic shock. Fluid loss is so great that it makes the heart unable to pump enough blood to the body. This type of shock can cause many organs to stop working. Now we also see decreased central venous pressure, that CVP, as well as weak, thready pulses and flat neck and hand veins, as well as tachycardia with a pulse over 100. Big test tip. So ask yourself, why is the heart rate high? Well, why though? This is because the body's trying to make up that decreased fluid volume by pumping the little blood it has at a faster pace all over the body to perfuse and oxygenate the tissues and organs. So the body's trying to compensate or balance itself out. This is what's called a compensatory mechanism, a big term that you will be hearing throughout your entire nursing career. Okay, moving on to integumentary, or the skin, with fluid volume overload. We see periorbital edema as well as pitting edema. Just think waterbed skin from that hydrostatic pressure. So increased volume causes fluid to be pushed out of the vascular space and into the interstitial space, resulting in edema. And we see pale, cool skin from all that fluid. Just think, the body is filled like a big water balloon that is cool to the touch. And on the other side, for fluid volume deficit, we have a really dry, skinny body, right? So we see sunken eyes, dry skin with pore turgor and tenting, kind of feeling like leather, as well as dry mucous membranes and increased body temperature. So write this one down. Many students get confused here. So just think, with a dry body, we have a high temperature. Or when the body's dry, the temperature will be high. Now moving on to neuromuscular. For fluid volume overload, we have altered level of consciousness, ALOC, with key term here, mental status changes, as well as headaches, which could mean that the brain is swelling from that cerebral edema, leading to seizures and death. We also see a client with weakness and paresthesias, that numbness and tingling in the extremities, feeling like pins and needles from all that fluid pressure. And for fluid volume deficit, we see lethargy to coma as well as weakness. Now moving on to renal and urinary. For fluid volume overload, we typically see an increased urinary output. But if the kidneys cannot compensate, then we see a decreased urinary output when the client has renal issues. For example, kidney damage. And for fluid volume deficit, we see an increased urinary output initially, followed by a decreased urinary output at the very end. Now it sounds a little bit tricky here, but just think about the patho here. If the client is urinating out all their fluid, well, all that fluid gets drained from the body and into the potty, right? Making the body dry. So eventually the body runs out of urine, resulting in decreased urinary output at the very end. So it makes a little bit more sense. Now moving on to respiratory. For fluid volume overload, we see a rapid, shallow respiratory rate. With key terms here, write this down. Rales or rales, with moist crackles. This means fluid inside the lungs when listening to lung sounds. And we also see pulmonary edema, basically fluid-filled lungs. And on the other side, with fluid volume deficit, we have rapid, deep respiratory rate because the body is super dry. Now for GI, the gastrointestinal for fluid volume overload. Increased motility leads to diarrhea. So again, just think about the patho here. The intestines get filled up with fluid, making the bowels like a big old water slide. Yahoo! And we also see hepatomegaly, an enlarged liver, and even ascites, where the abdominal cavity gets filled with fluid. Just think about it. This excess fluid has nowhere to go, so it starts filling up the organs. Now for fluid volume deficit GI, we see decreased motility, a very dry intestinal tract leading to constipation, as well as diminished bowel sounds, referred to as hypoactive bowel sounds. Like the water slide, it has no water, right? It's nearly impossible to slide down, so things naturally get stuck. Now for lab values. For fluid volume overload, think low when liquidy. We find very low diluted lab values when the body is full of liquid. This is what's called hemodilution, since all the fluid inside the blood is diluting the blood, kind of like adding too much water to your Kool-Aid or sweet tea. Now the Kool-Aid man usually says, "Oh yeah," but I'm going to have to say, "Oh no" here, since adding too much water to Kool-Aid or sweet tea is going to make it very dilute and pretty much tasteless. Well, in the same way, the blood is going to be very dilute with hypervolemia, making the labs very, very low and diluted when the body is liquidy. So naturally, we see a decreased osmolality, fancy words for a decrease in the thickness of blood, very dilute, watered down blood. And we also see a decreased hematocrit, as well as decreased blood urea nitrogen, that BUN, and decreased electrolytes, namely low sodium, hyponatremia, below 135, which is a huge risk for brain damage. Now, sodium is typically the most tested since it's the most critical, as severely low sodium from dilution could lead to deadly brain damage, called hyponatremic encephalopathy, which we'll cover in great detail in the electrolyte video. But just be sure to write it down. We have to monitor sodium levels during fluid volume overload. Okay, now on the other side, for fluid volume deficit, the lab values appear high when the body is dry. Again, the key term here is labs appear high when the body is dry. This is hemoconcentration, very concentrated blood. It's like adding too much sugar to that Kool-Aid. Oh yeah. How about oh no? We're talking too much concentration of solutes inside the blood, turning the blood to a paste, kind of like the blood is turned to mud. So think of the rhyme. Hemoconcentration is an indication of dehydration. When the body is dry, the labs appear high. So naturally, we see an increased osmolality, increased thickness of blood. Again, just think the blood is turned to mud. We also see an increase in hematocrit, as well as increased BUN and increased electrolytes. Once again, namely high sodium, hypernatremia over 145. We have a huge risk for brain bleeding. as hypernatremia can cause severe brain shrinkage here, resulting in vascular rupture and intracranial bleeding. Or in other words, the brain will be bleeding. Now, moving on to urine for fluid volume overload. Just think the urine will be low when the body is liquidy. So we see a decreased urine-specific gravity with low 1.005. Now, normally the specific gravity is 1.005 to 1.030 on the high end. So to make it simple, think low gravity is low weight with very dilute urine. Now, on the other side, for fluid volume deficit, once again, just think it's high when the body is dry. We see very concentrated urine. So increased urine-specific gravity. So high, 1.030. Once again, just think high gravity is high weight, very thick, concentrated urine. Now for tonicity of fluids. First up is the isotonic solutions. So just think isotonics are iso-perfect. We have a perfect balance of solutes both inside and outside the cells. So there's no fluid shifts, or in fancier medical terms, when solutions on both sides of a cellular or selective membrane have established equilibrium, or are equal in concentration. They have equal osmotic pressure, basically meaning the concentration within the cell is the same as that outside the cell. So there's no tug of war or pulling of fluid out or into the cell. We have perfect balance with iso-perfect. Now, it's important to note that human blood is isotonic. Thus, very little osmosis occurs when isotonic solutions are infused into the body, since they have the same osmolality as body fluids. And thus, it increases extracellular fluid volume, basically fluid within the blood vessel. So once again, the memory trick here, isotonic solutions, just think iso-perfect, like I'm so perfect. No fluid shifts, just perfect balance. Now, a big caution here. Too much isotonic fluids can cause fluid volume overload, that big water balloon body. So we must monitor blood pressure. And the key manifestation to watch for is hypertension crisis. We're talking a BP over 180 systolic. Huge risk for a CVA stroke. Once again, just think about all that pressure pounding on those little tiny blood vessels inside the brain. It can cause a deadly bursted blood vessel called an aneurysm. Now, the list of isotonic solutions that you should know for your exams, write these down. 0.9% sodium chloride. This is normal saline, as well as lactated ringers. Be sure to know these two for all your exams. Now, the uses of isotonic solutions, they're used mainly to add fluids intravascularly or inside the blood vessels to rehydrate the body and increase the blood pressure when it's low. So we give it for hypotension, that low blood pressure, in order to increase the blood pressure. We also give isotonics during blood transfusions to add volume during that blood administration. And we also give it to clients who are hemorrhaging or have had blood loss, as well as clients with diabetic conditions, DKA and HHNS, where the body gets overloaded with super high blood sugar, making the blood very thick and the body very dry. So clients are typically started on isotonic solutions initially and then move to hypotonic fluids. Now, speaking of hypotonic solutions, for hypotonic, think LO. These solutions have a lower concentration of salt or solutes than the ICF, the intracellular fluid, that fluid inside the cell. So write it down. Hypotonics have a lower osmolality than body fluids. So just look at the O's here with the hypo and the lower osmolality. So fluid is drawn into the cell via osmosis to make balance, causing the cells to swell up like a big fat hippo in hypo, or as I call it, hypotonic solutions. Therefore, these solutions should be given slowly to prevent cellular edema, basically cellular swelling. So for the memory trick, for hypotonics, think hippotonics. Cells swell with fluid like a big old hippo. Now, big cautions once again. Give very slowly to prevent cellular edema and cerebral swelling. basically brain swelling. And it's not for clients with ICP, that intracranial pressure, basically pressure within the brain. Hypotonics will actually increase that pressure even more, causing further brain swelling, leading to seizures and even death. So always give hypo very low and slow. Now for manifestations to monitor for, specifically cerebral edema, the number one sign is a headache. Number two is mental status changes, with a key term here, altered level of consciousness. Clients will appear newly confused, restless, or agitated, and finally progress into seizures and coma. Now for the list of fluids that you should write down. I know there's a lot, but you need to know these for your exams. So be sure to print out the study guides that we provide on this list of fluids. Now, and a little side note here, a critical thinking question that always confuses students. D5W, it's isotonic in the bag, but hypotonic in the body. Now, it's super confusing to many students, and this kind of stuff makes you want to quit nursing school altogether and become an Instagram influencer, right? Okay, I'm joking. But just know that D5W is hypotonic inside the body. Now for the memory trick to help you with all these fluids. As you can see, these fluids have a lot of numbers, right? So just think, hypo solutions, we have a lot of fluid inside the cell. So naturally, we have a lot of numbers preceding the solution, correct? So that's a little memory trick that you can use for your exams. Now, one of the main uses for hypotonic solutions is cellular dehydration, specifically with hypernatremia, that's sodium over 145. We have too much salty sodium inside the body, and all that salt piles up inside the bloodstream, sucking out all the fluid within the cell, which causes the cells to shrink, known as cellular dehydration. So that's why we give hypotonic solutions to fill the cell like a little hippo. Okay, lastly is hypertonic solutions. We have hypertonic, think high and dry. These solutions have a higher osmolality than body fluids. So it's very thick and salty solutions with loads of solutes, having more solutes and less water. So just look at the H here in hypertonic solutions for higher osmolality. So fluid is drawn out of the cell via osmosis to make balance, and this makes the cell skinny and dry, known as cellular dehydration. So these solutions have a higher osmolality than body fluids. So the memory trick here, hypertonic, think of a hyper person who is very skinny. So that hyper person with very skinny cells. Now a big caution here, we have to give this slowly to prevent massive fluid shifts from inside the cell and into the bloodstream, causing cellular dehydration as well as fluid volume overload. We're going to inflate that patient like a big old water balloon. All that fluid fills up the vascular space inside the blood vessel, causing hypertension crisis. So be sure to monitor for a blood pressure. And once again, the key manifestation is a hypertension crisis, a blood pressure over 180 systolic, huge risk for a CVA stroke. Okay, now for the big list of fluids that you must know for your exams. I know there's a lot here, but use our helpful memory trick. So as you can see, these fluids have very little numbers in front of the words, right? So we have a lot of 3s, 5s, and 10%. So just think, with hypertonic solutions, we have very little fluid inside the cell, so we have very little numbers like 3, 5s, and 10s before the words. Now, very lastly, hypertonic solutions are used for clients in hypovolemia, as well as heat-related or heat exhaustion issues, and even peritonitis and peritoneal dialysis. But it's really most commonly used in peritoneal dialysis to draw all that fluid out of the body and into the potty. All right, that wraps it up. Thank you so much for watching. Don't forget to take